Greetings, Dr. John Bennett from Miami Beach, home of Neurosurgical TV. Today we have the honor of hosting a neurosurgeon from Iraq, SAMER2, MD. He's a well-known teacher. He's going to be an even more well-known teacher in the future. And he's going to give a lecture today on neurosurgical operative anatomy, the second in a series of 10. And we also have distinguished panelist, Ulrich, but he's not using his photo because he's conserving bandwidth. Hello, Ulrich.
Hello, John. Hello, John.
No, that's a good idea. You're not using it. You're using it for introduction. That's good.
Yeah.
That's good. Okay, welcome, Ulrich. Go ahead, Ulrich, introduce yourself, please.
Thank you, John. Thank you, Dr. Samir. I'm Ulrich Sidney, final year medical student from Cameroon and future research associate at Harvard BGSST.
Okay, welcome. We're interested in following Ulrich there. Okay, Samer, welcome, and it's all yours.
Okay, thank you, John. Thank you for the Neurosurgical TV. And welcome, Ulrich. I always will call you Sydney. And we have also a new member. And today we will present our second presentation out of 10, which is about the neurosurgical operative anatomy, just to filling the gap between the regular neuroanatomy and what we need actually inside surgery. So I will start the lecture. Start slide share.
Okay.
John, I'm hearing my echo. Maybe something.
Okay, let me turn off things. Okay. Okay. Go ahead.
Okay. So again, neurosurgical operative anatomy. The title of lecture number 2 is the filling the gap between Snell's neuroanatomy and the Roton's microneuroanatomy, which is a big challenge and a big question need to be answered. Maybe we give some idea in this lecture, and maybe in the discussion we add more. I am SAMER2. I am from Iraq. I'm neurosurgeon, Arabic board and FRCS in neurosurgery, and actually I am a pure vascular neurosurgeon, dual trained, open and endovascular. I always start my lecture with this slide. We are nothing without our teachers, and we are shamefully inferior to them if we do not advance beyond them. Still some echo, John. So, these are the main 9 topics that we will discuss in our lecture series. And this is the one of 9 about filling the gap between Snell's and Roton neuroanatomy. So we will start to learn. John, I think someone needs to be mute. Still, I heard some discussions. John, do you hear me?
I'm sorry, go ahead.
I think one of the panelists need to get yes, that's it. So, starting with lecture number 1, which is filling the gap between Snell's and Roton neuroanatomy. And first of all, we already presented the first lecture about to start with the simple illustrations that usually represented by the Snell's neuroanatomy. Although it's a good book and it's widely comprehensive all over the world, but it's extremely simple to be a neuroanatomy book for a neurosurgeon. So I always advise my colleague and my students to start with the Snell's neuroanatomy, but it will end about 1 month. 1 month is more than enough for Snell neuroanatomy, because in this type of books, you always will find such illustration. It's nice, it's comprehensive, You can figure the whole idea or the big picture, but it's not related to reality. It's not related to operation. These are other examples of illustrations, simple illustrations, like it's a neuroanatomy, but it's not a pure neurosurgical anatomy. And actually, these slides are usually just to remember, to memorize more than to study or to do surgeries. That's the part number one, which is Snell neuroanatomy, and what this phrase represents. It's represent the simple illustrations. And the other point, the other side is the Roton neuroanatomy, which is the microanatomy, the detailed microanatomy, mainly based on cadaveric dissection, injected cadaver, the arteries with red, the veins with blue. That's a very clear anatomy. It's a new era of anatomy done by Roton, but still, the point is you as a neurosurgeon resident or as a medical student interested in neurosurgery or even as a neurosurgeon, you cannot neglect Snell's neuroanatomy, the basics, and jump directly to the Roton type of books. And actually, if anyone try this, he will remember what I will say now, that you cannot start directly with Roton. You need a lot of assistant resources before starting with Roton. Maybe the first chapter of Roton book is about the gyruses. Maybe it's easier than the others, but when starting with the vascular chapters, it's totally different. It's a difficult one. I always advise just to read the introduction, the parts of the carotid, the introduction of anterior cerebral, introduction of middle cerebral. That is the most important part to start with in Roton. And after that, you must stop and fill the gap, which is the topic of this lecture. How I fill the gap between the the simple illustration and the Roton microanatomy. I will suggest some resources and discuss it one by one. One of the resources is the illustrations, and it's clearly beautiful. But if anyone neurosurgeon or especially vascular or doing microsurgery, he already knew that this illustration is a fake illustration. I can tell that this illustration is not real if you figure it in detail. I will use this laser pointer. Yes, this is the Sylvian fissure filled with single artery and give many branches, and this is not a reality. For us, we call it this an anatomy, gross anatomy, or pure neuroanatomy. It's not a neurosurgical anatomy. Another slide, yes, by this illustration, it's a nice illustration, but for us as a neurosurgeon, it's a wrong illustration. It's not, it's a fake illustration. Why? Because the Sylvian fissure is filled by a main stem or main artery, which is not real. The Sylvian fissure, maybe you must get in deep inside the Sylvian fissure, at least 1 cm to get the main trunk, which is not one trunk, always 2, maybe 3 trunks. So this is a good image, a good illustration, a good companion to study, but it's not real. Another image, yes, it's nice, demonstrate the anterior cerebral, middle cerebral, posterior cerebral supply of the cortex, but also it's not a real image. Why? Because it demonstrates too long and first segment of middle cerebral artery, the M1 segment, is too long, and actually M1 do not reach the lateral surface. Another example, okay, this is a good example. This is a real picture. We can use this illustration while neurosurgery studying. Why? Because the Sylvian fissure is empty without main stem, and always there is a branches, and it's with the range of 12 branches arises from the middle cerebral artery in the Sylvian fissure. So this is a nice one. And also this is a nice one. It's totally different from the picture that we start with, because here the Sylvian fissure is empty, no main trunk. Always you can see the branches of the middle cerebral artery, not the main trunk. And also it's nice, they demonstrate the pars space, which is the widest part of Sylvian fissure when you can start to dissect and start the surgery. So I gave here an illustration of how the cortex different from illustration to illustration. And actually it's confusing at the start, but later it will get better with the time. Another example is the cross section. If you can figure this, let's start with the figure on the left side. It's a direct anatomy. There is no curvature in the middle cerebral artery from bifurcation, direct without curvature. And what's this branch? It's a third, it's a trifurcation. Where does this branch go? We usually don't have this branch from the bifurcation of the cerebral directly to the cortex. So I think this is not a correct illustration. Always in this type of illustration, there is a lot of wrong illustration. And I suggest you, I encourage you to use the theory part to pick these mistakes. And this is more reliable. This is the reality. This is the type of bifurcation of middle cerebral artery and the Sylvian fissure. And these are parts of middle cerebral artery after bifurcation. And one in the proximal Sylvian, we call this sphenoidal part. Then the second part should be longitudinal, which is the insular part. The third part is the opercular, and the final part will be the cortical branches. So this illustration is a more scientific, it's a neurosurgical illustration, we can use it. And what's this? I don't know. It's not related to neurosurgery for sure. Always circle of Willis, if you can figure the middle cerebral artery shape and direction within the pictures or illustration of circle of Willis, you can easily identify that it's not real. Usually there is no such long segment in the middle cerebral artery without the branches. At least anterior temporal branch, at least it will be a bifurcation at the end. Also, other example of, I should tell that it's a fake or not a real neurosurgical illustrations. Like this one of circle of Willis, or maybe this showing the aneurysm. It's nicely with jokes, but it's not a neurosurgical illustration. Maybe this one is good, but what's the benefit of studying many branches extra, which is not the main branches? Another point, maybe I will put this like a test. Just anyone will on the panel, or anyone will see the video later. I will ask, what's this? Clearly the optic, and carotid. And what's this? Is clearly it's aneurysm. Is it the usual site of aneurysm? No. Aneurysm in which artery? Carotid bifurcation, usually middle cerebral, so anterior cerebral. What's A1 and anterior cerebral artery aneurysm? It's a very rare entity. Usually 40% of all the aneurysm in the anterior communicating area. So this is not usual. You must keep this in mind when studying such books, because this is rare cases. This should be not your regular anatomy or regular picture in mind. Another example, but I should ask some question. Is usually the carotid artery crossing the chasm? This is not usual. Maybe pushed by a retractor, but I don't see a retractor here. Is the anterior cerebral artery, this is the usual direction of it? No, usually the direction more posterior. What's this? It's a basilar tip too high from the dorsum cili. This is not a usual scenario. Also, what's this? Third nerve insertion is far away, usually more medial. This, like some objections, I will pretend here that we will pick some objections from some pictures just to enhance the idea in your mind that everything is can be questionable, and when you study deep in the neuroanatomy, you must ask yourself about each of the illustration. Is it real or not? Is there any mistake or not? Another example, which is a very nice picture, they looks like a giant pituitary adenoma with the transcranial approach, and they drill the tuberculum cilia to get, or the part of the planum to get down to the cilia and resect. But let's get a close idea first, or a close look. First of all, what's this? This is the recurrent artery of Hubner. If I will illustrate this again, I will put it just 2 millimeter more superior, because 80% arise from the A2 just at the beginning, just at the attachment of anterior communicating artery. This what will build your anatomy. A closer look to the same image. What's these two branches? Is it the superior hypophyseal? I think it's the superior hypophyseal, but it's two late branches. Usually the superior hypophyseal is the second branch after the ophthalmic. And what are these? The choroidal and pecum. Anyone doing surgery knows that this is not the usual size. Usually larger if on fetal time. And why the carotid bifurcation without perforator? Always there is a perforator from the carotid bifurcation and from the M1. Why only the A1 has a perforator? These are questions. I think it's a big questions for a neurosurgeon to revise the already present illustration within the books. That's part one about how to use illustrations and how to dig in details in illustration. Another suggestion is to use the radiology angiographic wise or MRI wise. It will be very helpful. It will be more close to the reality. If I am studying the mid-cerebral artery, it will be very nice that I see the bifurcation, M1, M2, all these branches are M3 and the cortical are M4. These will be a nice studying guide. Always I try to use radiology just after illustration to see the reality or see from different point of view. These are illustration of the cerebral artery, very clear bifurcation, very clear angle, very clear early branch of anterior temporal. These will be known as the operative neuroanatomy that you need, not a simple illustration. And also on the other side, you can see there is a spasm or maybe closed the cerebral artery. Another example of the radiology, anyone can answer this. What's this? For sure, it's aneurysm. Where the aneurysm? It's in the, where? 1, 2, 3. The answer is mid-cerebral artery early. Let's take it. This is the carotid, the supraclinoid carotid. This is carotid bifurcation, A1, A2, anterior communicating, and maybe this abnormality, I want to see it from the other side, maybe some aneurysm. And from the carotid bifurcation, this is M1 up to the bifurcation, and usually the bifurcation within M1, and these will be M2. I will suggest this as M2, and these are the bifurcation branches from the M1, and finally M3 before the cortex. So this is very unusual site of aneurysm to be on the superior surface of M1 just before the bifurcation. This is how we study the vascular anatomy in deep details. Every vessel, you must know it in details before getting to the real vascular anatomy. Angiography will be always helpful. You can see the anatomy of arteries from different angles. These are very nice illustrations of the branches of the arteries. And also stick to the mid-cerebral artery. What's this? Is this the mid-cerebral artery or this? For sure, this the right side is the right one is the mid-cerebral artery, and this is the anterior cerebral artery because lesser branches and go directly up. But here is the giant mid-cerebral artery bifurcation aneurysm, and we can easily appreciate anterior or early temporal branch inferiorly and some perforators superiorly. Another example is another aneurysm, which is more typical to see this type of aneurysm is the MCA bifurcation aneurysm with the early temporal branch. Very clear, and usually there is maybe trifurcation as seen in this figure. So this is a very good type of studying anatomy, always to try it when you are studying mid-cerebral artery, like in this example, always try to see, search for mid-cerebral artery, MRI mid-cerebral artery, angiography to see the real anatomy more. Another level is to use the high scientific-based illustrations. These are some example of how you can divide the Sylvian fissure into segments and study each of them. Where is the mid-cerebral artery inside? And we can use the simulation for that. So after this introduction, we get to the Roton again. I think now this is the time of Roton after getting some illustrations, some pictures, some imaging, and study in the theory part, the main part. After that, we get to this point. At this point, the Roton book will be, or the Roton type of illustration will be very useful, and it will lift you up to the next level. These are some examples of how Roton divide the same artery that we give as example as the mid-cerebral artery, the variations, the territory for the 12 branches, and more detail about the variation. So if you want to get this, there is a series of resources you must study before. Another method is to use the cadaveric anatomy or cadaver-based anatomy, but I don't know what's this, but someone died before more than years. And this is another example in the books about cadaveric anatomy. I'm not satisfied with this type. I feel like something with a lot of makeup. Even the optic nerve is pinkish. I don't know why in this figure, but it will be helpful source also. Another example for cadaveric, it looks like a roasted mid-cerebral artery. I'm not happy with this type of cadaveric illustration, but it will be helpful. And maybe each cadaver have different color. It depends on the injection of the material or the material injected in the arteries and veins. So always a cadaveric study is an important, whether cadaveric picture or cadaveric course, but always keep in your mind the variation. The variation is the most important here. Even a closer look, this is the nicest thing that you can see. We call it operative or intraoperative knowledge or teaching or studying of anatomy. When you get inside the surgery, assisting in surgery and doing surgeries like these, splitting the Sylvian fissure and searching for mid-cerebral artery aneurysm, and it's unruptured one, so the anatomy is more clear. Even after clipping, it's very nice. This is the mid-cerebral, and this is the aneurysm clipped, and the branch that it's just above the dome of aneurysm is this branch with magnification. I think that's our target when doing surgery, but before that we need some steps to dig in the neuroanatomy before reaching this level, and actually this is the nicest one to be studied. So this is a general idea about how to fill the gap between Snell neuroanatomy and Roton neuroanatomy. I will give some examples from the books. These are the illustrations that we talk about, and I always, when I study illustration, I search for mistakes. Because these are neuroanatomy, not a pure neurosurgical anatomy. That's the big difference. And there's a lot of examples in the literature. Someone searching about the anatomical error in the anatomy textbook and atlases, and a recent publication, 2011, anatomical error of illustration. And they describe some example of how far the origin of cranial nerve as put in the book, while this is the truth, and how far the intraoperative curve of the vessel as the opposite to the depicted in the illustration. Always there is a variation, but why the sixth nerve here, but in reality it's lower down, not at the same level. So there is a lot of mistake, and you always keep your eyes on these points. Using 3D model, it's very nice, it's very effective. Always, whenever you study anatomy, please keep your model beside you, a brain model, a spine model, a skull model. You need them all at the same time. And another way I support this application, I think it's very interesting. It's of our friend Federico Nicolosi. It's upsurgeon application. They are developing more and more application. But for a skull, if I am advising a medical student interested in neurosurgery or a resident, neurosurgery resident, please study the skull using this illustrative app. It's a free app and it's very useful with the all detail, with all the bone separated. You can study each bone alone and getting into the cranial cavity. Even the Tyler-Houghton complex line or Tyler-Houghton lines are demonstrated in scientific details. And also they put some new application from the upsurgeon also as a simulator. You can simulate the whole surgery, not even in the normal anatomy, but also use how to position the patient. And that's very important because you will get a field more close to reality. So there is a lot of application for sure, but for me, I think this is one of the best. And angiography, we discussed the importance of reading imaging, angiography, MRI, along with studying the neuroanatomy. This will give you another perspective of studying because the details in angiography is the extremest details, is the most detail that you can find about any structure. Operative books, always nice to understand from where they approach this figure, what are the point of the illustration, but usually it will be a part, but not the typical one. Always cadaver is better, especially something with this color like fresh cadaver. It will be the best to to upgrade your learning of anatomy. You will start learning anatomy from the basics, but the real upgrade is here near the cadaver or near the operation. So even in some article discussing what's the best tool, whether teaching or studying, either dissection or prospection. For those who don't know, prospection means that the cadaver already dissected and there is an illustrator that demonstrates the anatomy. But I think the dissection will be more fun, especially if you have a knowledge before the theoretical knowledge. Then you can add this as the dissection courses, or you get back to the anatomy department to get more and more dissection. This is the most valuable like changing point between a resident and surgeon. From resident to surgeon, you need to do cadaver course. It will be more fruitful at this period because it will give a good permission or step forward to be a real surgeon. Another example, maybe the last example of this lecture, that a lecture presented by two of my students. They are third-year medical students here in Iraq, and they are really interested in neurosurgery. They present a presentation about trigeminal neuralgia, and they follow I think it will represent the today lecture, how to fill the gap between the basic, clear, simple anatomy and the roton anatomy. This is some slide from their lecture. That was a nice presentation. I think it's already on the YouTube. They start with this slide, then get to more 3D anatomy, more sectional anatomy, then sectional cadaveric anatomy. It's very nice to demonstrate how is the trigeminal cisternal segment and the inside the Meckel's cave, and radiological anatomy of the trigeminal, more radiological about Meckel's cave and the CP angle, then get back to roton. So this is how to fill the gap, because if we start with this roton picture, it will be like without knowing the origin, the end of the trigeminal, the parts from where start and to where it ends. And also some topographic illustration from where the fiber that going without inside the trigeminal nerve. And they discuss, and actually I'm interested of this topic. It's a pure surgical topic. If anyone know about trigeminal neuralgia, the main cause is a vascular compression, and for vascular compression, we usually do microvascular decompression by using this method, which is, we call it the interposition. But during my Japanese fellowship in South Tokyo Hospital, they use this one. It's very interesting one, to use interposition instead of transposition instead of interposition. Why I should put a Teflon piece between the artery and the nerve? Because I can put like a sling to pull the artery away from the nerve. It's an interesting idea. It's used around the world now, especially for recurrent cases, and it will be demonstrated here. This is a cross-sectional axial MRI showing the trigeminal nerve exiting from the pons, and it's split trigeminal nerve. Why? Because there's a conflicting vessel. You can find two vessels just besides the trigeminal nerve. And this is the intraoperative picture. That's what I want to bring now, is the intraoperative illustration. If someone asks himself now where I am, for sure you will open, and if you are the operator, you know where you are here. But supposing doing some trigeminal surgery, it's clear that this is the trigeminal nerve. But what are these structures? Usually a vessel above the trigeminal, mostly it's ACE or below trigeminal superior cerebellar. Remember always, this is an upside down anatomy. And if you see a vein crossing the trigeminal, this is mostly the vein of metacerebellar peduncle. These are detailed microanatomy related to the approach, which is the maximum level of anatomy we need. And this is the nice illustration done by the professor at this surgery. This is a surgery we did in Japan, and how nicely he illustrates the trigeminal nerve, the compressing element. There is a three compressing element. The main compressing element, superior cerebellar artery compressing and like entering inside or pushing inside the nerve, and the vein of middle cerebellar peduncle crossing above the nerve. And here, even in the proximal part of the trigeminal nerve, the AK is there. So this is the most important step, is the operative neuroanatomy, and you will see inside the surgery. I'll show this video.
You okay, SAMER?
I hope so.
Okay.
Just yes, I'm okay.
Okay.
So this is an intraoperative demonstration of the same case with the illustration we already showed. This is the trigeminal. There is an artery just pushing the trigeminal, which is the superior cerebellar. You will see how to dissect this artery. It's a retractor-less surgery. Some dissection, you need to sacrifice some small branches. And now you can see, yes, this is the compressing vessel, easily to be dissected from the trigeminal. And another step, this is at the end of surgery. Let me remind you that this is a type of transposition for management of trigeminal neuralgia. Means that you pull the vessel away from trigeminal. And our professor at that time is Professor Hidetoshi Kasuya. Usually focuses on the root entry zone. If anyone understand where we are, I should ask here, if this is the trigeminal and this is the ACA as we demonstrate, so what's this part? What's this part of the brain? If we know this part, if we try to figure what's this part, like this one, because this is the trigeminal, okay, and this is some artery, and what's this? root entry zone. This is a bones, so the answer is the bones, and here we are dealing with a small perforator just on the bones.
Those are quite good tools.
And this is the illustration of Professor Hidetoshi Kasuya. You can figure on both, please compare the left with the right side. Left side, the intraoperative finding, and the right side is the post-operative. There is a bridging vein above the trigeminal, which is the vein of middle cerebellar peduncle, and here we just push it with a Teflon and using a Teflon and fibrin glue sling. And also this is the AK pulled away here from the trigeminal root entry zone, and the main compressing element, which is the SICA or the superior cerebellar artery, pulled away and slinged to the cerebellum by also by a Teflon and fibrin glue. So the final result will be the trigeminal nerve clear. This is from operative point of view, but from anatomical point of view, I think this case will illustrate what we mean by more than roton level of anatomy, that you must study roton in detail, and after that get close to the operation, get familiar with more operative video to so you can understand these types of anatomy or complex anatomy. Actually, we have an article about this type of transposition for posterior fossa cranial nerve, and we suggest a scheme, and this is a demo also based on anatomy, and the last video will be
It's frozen again. Okay.
oops. Maybe this is an upside down video, sorry, but this is the sling, this is the Teflon ring. I'll try to use the pointer. Oops. Yes. So this is the trigeminal, and this is the compressing element. Let's suppose it is the superior cerebellar artery, which is the most common, and this is the Teflon ring or the Teflon sling, and just pull the artery after dissection for sure. And here we can put a few drops of fibrin and then a glue. We use a fibrin glue as a sticky material. It will stick on the brain tissue without injuring it, without a harmful effect. And the most important, you can see how clearly the trigeminal will be left after the surgery, and it will be totally depend on anatomy. And for sure, this sling should be not a tight one, to just not to close this artery or not to constrict this vessel. So this is what we mean by the sling method for transposition of the conflicting vessel of the trigeminal. And yes, now you can see how easily to do that and how clear anatomy. And this is the pushed vein already, the middle cerebellar peduncle vein. That will be the end result for that. Take home message: always try to combine different resources or different type of resources when studying in neuroanatomy, and see one, do one, and teach one. Draw it to know it may be the best and the most helpful one to study and to teach neuroanatomy at the same time, especially from a neurosurgical perspective. And as I said before, William Harvey said, I learn anatomy not from the books, but from section, not from tens of philosophers, but from the fabric of nature. And why we focus on such anatomy? Because surgery is anatomy, maybe 90%, and 10% is hemostasis. Next lecture we will discuss how to study the operative neuroanatomy based on the, we will put a 3 level, the basic level, the intermediate level, and the advanced level of what are the resources that I can study, like a scheme. I think it will be helpful for students interested in neurosurgery, for residents, in neurosurgery, and even for those aiming for subspecialty within the neurosurgery. All this should be done by team, and thank you.
Okay, excellent, excellent, sir. Another great lecture. Let me introduce some people that came late that you didn't meet. Warlix, can you please introduce yourself to SAMER? Are you still at Warlix? Or are you studying for your oral exam? She's getting ready for oral exam. He's getting ready for oral exam.
Hello,
are you there, Warlix?
Hello, Elena.
There she is. Okay, Warlix, please introduce yourself.
Hello, Warlix.
There she is. You're muted. I can't hear you, Warlix.
I don't know where is John.
You can hear me now, right, SAMER?
Hi.
There she is. Okay.
Yeah, I am neurosurgical resident. Nice to meet you.
Yeah, you mentioned Japan, SAMER. Warlix may go to Japan also. So anyway, okay, Elena, welcome.
Hello, everybody. Thank you.
I don't hear you, Elena.
Presentation, Dr. Samer. I really enjoyed it. I am a fifth-year medical student, and I'm president of the Walter Itendi Neurosurgical Club from Romania.
Right, welcome, Elena. And we may try to do a weekly neurosurgery news, and we'll talk about that later. And Pham, can you hear me? Pham from Vietnam, I believe. Can you hear me okay, Pham?
So if anyone has a question, maybe put it in the chat. While,
okay.
Waiting for John.
I'm sorry there, SAMER. I'm kind of interrupting. Is there a question there? Don't see it yet. I guess Elena is typing one out. Mohammed, can you say hi?
John,
Hi, everyone.
Go ahead, Mohammed.
Hi, everyone. Hi, Dr. John. Nice lecture from Dr. Samer.
Where are you from, Mohammed?
I'm from Iraq. I'm a student of Dr. Samer and interested in neurosurgery.
Welcome.
Thank you.
Welcome. Okay, Ahmed, do you want to introduce yourself? Are you there, Ahmed? Perhaps not. Okay, I don't see that question. Where is that question? Is it on YouTube? Let me check YouTube. Okay, any other questions or comments from the panelists? Ulrich, Ahmed, or anybody?
Yes, I would like to ask two questions.
Go ahead, Elena.
First of all, I suppose you use the retro-sigmoid approach for the trigeminal neuralgia in cases of vascular cancer.
Did you hear that, SAMER? SAMER, did you hear that question? Whoop. Where'd SAMER go? SAMER, did you hear that question of Elena?
Is my sound all right? Can you hear me?
I don't know if SAMER, did you hear Elena or not? I guess he's having problems with the audio. SAMER, you want to play with that audio? Because you're the key man here. Can you hear me, SAMER? I think he's having problems with his audio, unfortunately. So we'll be patient with this technology. Sometimes things in the OR don't go as planned, and you have small little bleeders, I imagine. SAMER, are you there? We may have lost SAMER for a second there.
He tries to log in.
Well, the Warlix is preparing for oral exams.
Good luck.
Okay, well, three separate presentations, correct, Warlix, right?
Yeah, it's interesting for me because I like to do the illustrations myself too. But for me, like in his will, medical illustration for him it's like educations or illustrations for a book. But for me, I am neurosurgical residents in last year. I would like to maybe it's not only to education, it's also useful for the neurosurgery residents or surgeons. I mean, anyone who maybe you can try to illustrate by yourself. I mean, yeah, so it's gonna be useful. It's not only help you to study, help you to remember, but it's also help you to like the operative planning.
And there, so how much time do you spend with each team of 3? An hour, half hour?
Excuse me, John. Dr. Samer is around, and can you please upgrade him to a panelist?
Oh, okay. Thank you. How long do you spend with each three neurosurgeons? Okay, I'm sorry. Samer's back. Okay, Samer. I'm sorry about that. Okay, let me unmute you. And I believe Elena had a couple of comments or questions. Are you there, Samer? Can you hear me okay? Can you hear me okay, Samer? Okay, you know what? Maybe you can write the question, Elena, in the chat, and I'll relay it, because apparently Samer's having problems with the audio. Just type it in the chat box, and I'll relay it. Can you hear me yet, Samer? No? Can other people hear me?
My question in the chat.
Yeah, you can hear me, but I guess. Hello, Samer. Hello. Yeah. You know, it's funny. I can hear his keyboard, but I can't hear him. Yeah, did you write that question? Okay. Okay. Retro Sigmoid approach. Okay, I'm going to try to get that to Samer. Yeah.
Hello.
Okay, yeah, I'm typing. To use a retro sigmoid approach for trigeminal, right? For trigeminal neuralgia, Elena?
Hi, John. Do you hear me now?
Hey, yes, I can.
Yes, I get the idea.
Okay, Elena has a couple of questions for you,
yes.
Samer. Okay, go ahead, Elena.
Thank you, Dr. Samer. I would like to ask you, what we saw was the retrosigmoid approach for the trigeminal neuralgia, right?
Yes.
And how many cases a year do you have of Janetta, let's say, modified Janetta?
Sorry, how many cases?
Operations of this type do you have per year? Is it a frequent pathology in your department?
Actually, two different experiences. This operation and this type of surgery is from Japan, and where I did my fellowship, and it's quite common there. And even I think the last patient we did age like 90 something, 94 or 95 age. So they did it in common, and for the last 10 years they have a study about that. They are all using the transposition instead of the interposition technique. So it's quite common there. Here in Iraq, I'm now practicing in Iraq, maybe temporarily, and we have some cases, but patients more like the direction of doing it in minimal invasive way, like using the gamma knife or stereotactic radiation.
Thank you.
So less surgery here, more surgery in Japan.
Oh, I see. And I was curious about the technique. Was there any case in the literature reported to cause artery stenosis after this procedure?
To be honest, there is nothing about this, as I know, because I'm already doing a literature review just before a few months. There is no reports about a problem, but you do not expect a report about technical notes. When there will be a large series, yes, after a large series, you can see the complication in the literature, but now they are focusing on the technical points. So there is totally different, maybe about 15 different way to how to use a sling. What's the type of sling? You can use fascia, you can use aneurysmal clip, fenestrated aneurysm. There is many different ideas, but what's found in the literature that technical reports about using this method, technical report about this using this method. So they are not focusing about complication. For sure, they are concerning about that, but maybe it's a technical more. Maybe I'm thinking about using fascia, but I'm afraid that fascia with the time maybe get fibrosis and causes stenosis of the vessel as you think, and that's my idea too. If I use a fresh tissue, like using some fascia from the periosteum, maybe with the time fibrosis will constrict the vessel and will be we may have some ischemia. But in reality or in literature till now, it's not proved.
Thank you.
Okay, thank you.
It's kind of a general question from a non-neurosurgeon. Is Japan known to be a center of vascular neurosurgery? Is it tops in the world? It seems that way from the way people talk about it.
Sorry, I don't get it, John, sorry.
Yeah, is Japan considered the center of endovascular surgery? Are they considered tops in the world? Would you say?
It depends of the perspective. Maybe Japan, one of the top neurovascular centers around the world. It's proved, especially for the vascular, and they have like endemic diseases like moyamoya disease or some disease more common in Japanese population. Even the aneurysm, one of the highest population, maybe only after Finland in the whole or worldwide, it's Japan have the highest incidence of aneurysm. So it's advanced, yes, advanced, and it's one of the top, yes, one of the top. Maybe only different from the budget for the research. That's the what the state is on the top of it.
During residency, are the residents exposed to more endovascular work in Japan? Are the residents themselves?
Yes, yes.
Yeah, because of that reason, right? Because there's more aneurysms, more moya, etc.
Yes. Although in Japan, the percent of resident and the neurosurgeon to the population are one of the best in the world. I mean, number of surgeons per population.
Okay.
So there's a lot of neurosurgeons, and
right.
But at the same time, there is a lot of work and a lot of cases, mainly vascular, whether open vascular, microvascular, or endovascular.
I think Naru had a question. Naru, do you have a question? Hello, Naru, welcome.
Hello, John, how are you?
Fine. Could you please introduce yourself and ask your question?
Yes, I am Nuru Bankol. I am a resident in WFNS Rabat Center in Morocco here, reference center of training of neurosurgeon in Africa. Nice to meet you, and I was late because I was in operate room, but I saw the end of your presentation. It is beautiful, and I know more than about neuralgia, trigeminal neuralgia, and nowadays it is obviously it is clear that neurovascular decompression have good outcome, like against percutaneous technique, balloon technique of balloon, but now we know that neurovascular decompression is very good. And in my department, our department here, sometimes we don't combine approach with neurovascular neurovascular decompression with microscope and endoscopy to have good view about the artery and vein and nerves, and put between Teflon. but me, I don't do this decompression yet, but I perform good the retrosigmoid approach, and after my prof come to done decompression. So it is one technique that I saw many times, and good work, and thank you for your presentation.
Thank you, Nora. Actually, I agree with you totally, but I think this is the advanced one. Maybe you can discuss with your professor. What about the transposition instead of the interposition? I think it's not a pretty new, but it's a new one too. Why not? Maybe not your professor. Maybe you will try it in the future.
Yes, yes. No, it is beautiful. Your technique, it is very beautiful, and I will talk about that with my prof, and I will learn in literature about that. But it is very nowadays we always we want the best approach, the best technique to have a good outcome. So it is welcome your technique, and I appreciate that.
You're welcome. Thank you.
Welcome.
Okay. Any more comments or questions from the panelists? You know, Warlick's made a remark. She doesn't use the retrosigmoid approach. I think you were referring to the prior question, right, Warlick's?
Yes, is retrosigmoid approach. Yes. The
Are you there, Warlick's? She may be studying for her oral exam. Well, okay, there she is. Would you mention you wanted to talk to Elena about the retrosigmoid approach? Excuse me, retrosigmoid approach. You said you don't use that at all?
No, I did not say no, but I just want to share my experience that, but I think it's, we generally use the retrosigmoid approach in the microvascular decompression in trigeminal neurology. Yeah, it's normal. And for the interpositions, transpositions, but I just only want to share that in my experience in assisting my teacher for the trigeminal neurology cases, I have never seen any case that have artery stenosis. Very minimum, because right now we kind of like use very meticulous techniques, and we have the nerve monitorings and everything, so it's very precise. And according to the like Dr. Sams or our professors, that they have really high skills of the micro surgical skills. So yeah, I only want to share. That's all.
Yeah.
Thank you, Warlick.
Welcome, Alex. Understand your point, but I put a direction for that. If you study the recurrent cases of trigeminal neuralgia after microvascular decompression, that's the idea. If you study why they do reoccur after the interposition of Teflon, studying of these complication, let's say, or why the cause of recurrence, give some idea about what we need to do next, something we need to do other than the simple interposition of Teflon. Sometimes even there is a Teflon adhesion to the trigeminal and will be the cause of recurrence of disease, and that may be an idea for the future. I try to encourage a new colleague, maybe like you assisting now, in the future you will try it in difficult cases or recurrent cases. And another point, that if you study why in the recurrent case of trigeminal neuralgia, you will find like a good percent, maybe 10 to 14% of the cases of trigeminal neuralgia, it's of multiple conflicting vessel. The origin is multiple conflicting vessel combining arteries and veins, and that require maybe different technique. Not always, you cannot put the Teflon for two structures on the two sides. So you may need it inside the surgery to use a sling.
Experience the case that come with trigeminal neuralgia, but for the intraoperative view, you cannot see obvious artery or veins that complex the most exciting zone. Have you experienced that? Because there's a few cases that I existing my teachers, and there's a few cases like that. So sometimes we did not push any Teflons. Sometimes the patients like relieve by themselves. Sometimes it persists. So like, have you ever experienced that?
If you are talking about the conflicting anatomy inside, sometimes artery similar to vein, I think this is the first part of your comment. Yes, maybe similar. Sometimes the vein is not clearly darker, but I think some dissection, more anterior, more posterior, you will get some idea about the origin. And also, it's the familiarity with the case. For you, if you want to do this as a surgeon in the future, I will suggest 3 days before the surgery to see all the microvascular decompression videos that you can get from YouTube, from your from your library. Familiarity with the view, familiarity with the videos or intraoperative views will give you a better idea about that.
Thank you.
You're welcome.
Any more comments or questions for SAMER? Okay, SAMER, thanks a lot
Thank you.
first of all, for rescheduling and doing it the next day. That's great. I thought we lost this week, but certainly it was a great conference. And we look forward to next week. The topic is what's the next topic next week, SAMER?
How to study the operative neuroanatomy. I think it will be a scheme for resident, for a student, and for a young neurosurgeon. What are the books that should be and must be and maybe? I will put it like this.
Excellent. Okay. Thanks everybody for coming, and we'll sign off. And you can stick around and network. Thank you.